This is a commentary article where we make the case that the increased prevalence of alcohol use due to COVID and its downstream impact in terms of increased demand for addiction services needs to be managed proactively and innovatively, leveraging current evidence-based treatment models, implementation science, and digital modalities, yet ensuring health equity, financial viability, and careful implementation. My name is Celia Kameth. I'm an assistant professor of health services research and an implementation scientist with the Department of Quantitative Health Sciences, with affiliations with the Kern Center for the Science of Healthcare Delivery and the Knowledge and Encounter Research Unit here at Mayo Clinic. I will be joined later in the video by two eminent psychiatrists and co-authors, Drs. Terry Rummans and Scott Breitinger, who will introduce themselves and add the clinician and patient perspective. In this video, we discuss our manuscript titled Shaping the Screening, Behavioral Intervention, and Referral to Treatment Model for the Treatment of Alcohol Use Disorder in the COVID-19 Era, which will appear in the October issue of Mayo Clinic Proceedings. In essence, in this commentary, we propose an innovative adaptation and integration of a couple of evidence-based treatment models together with emerging digital technologies and careful implementation strategies to create a powerful treatment approach for increasing anticipated demand for COVID-related alcohol use treatment. So let's first start with a screening, behavioral intervention, and referral to treatment approach, SBIRT for short, for treating alcohol use. This consists of three components: screening to assess the severity of alcohol use and appropriate level of treatment, brief intervention to provide awareness of alcohol use and increase motivation to change, and referral to treatment for those needing more extensive treatment, including access to specialty care. A more assertive modification of SBIRT includes recovery management checkups, where routine care checkups are proactively scheduled for patients with a dedicated focus on higher risk patients. But despite its evidence-based use of SBIRT for alcohol use is limited due to scarce resources, lack of skills, skepticism that it works, and insurance barriers. We propose integrating this approach in primary care with another evidence-based model, the collaborative care model, already being used for managing several psychiatric conditions in primary care. This model is essentially a collaborative effort between primary care physicians and a specially trained behavioral healthcare manager to screen and treat patients for mental health under the supervision of a licensed psychiatric physician. This model used to treat a variety of psychiatric conditions in primary care settings is financially viable and has billing support from several public and private payers. So the potential value of this integrated SBIRT model for treating alcohol use in primary care would basically be to increase capacity for treatment while optimizing ongoing scarce psychiatric resources. Referrals and monitoring could further be augmented through what we refer to as the recovery management checkups integrated into primary care workflows. Now, moving to digital interventions, these have been supported by preliminary evidence in reducing alcohol use. Digital interventions include telemedicine, mobile and web-based applications that have created scaling, continuity of care, and new methods of patient-centered alcohol treatment. Further, tele-expertise, where an addiction specialist can distantly supervise the work of other health professionals, can additionally support telemedicine. Other digital health interventions, such as programmed therapeutic relational agents and wearable devices, could provide additional personalized treatment support, improving access. Now, taken together, these interventions can reduce the population-level burden of pandemic-associated alcohol use. However, with all promising innovations come certain caveats. Here, we need to pay special attention to the potential for disparities, poor implementation, and payment policy to support what we propose. First, as we note, digital interventions offer the promise of breaking down some barriers to access, but they also leave patients behind due to lack of access to smartphones, computers, or the internet, especially for poor and racial and ethnic minorities and rural communities. Digital health equity also extends beyond those with low socioeconomic means to patients with poor area-based digital connectivity, limited digital literacy, and age-related cognitive declines. Fortunately, there are emerging solutions to this problem by way of new inclusive implementation strategies with a broad range of end users in mind, including those requiring safety net and digital health literacy support. Second, amendments to existing payment policy by state and government agencies are needed. One example of payment reform would be providing the right incentive to clinics and providers to find ways to decrease the digital divide by providing digitally challenged patients the needed skills, example through digital access training, resources, say with iPads, and support through perhaps digital navigators. Finally, we need to ensure that these proposed new work arrangements are taken up through an essential set of implementation strategies. Many clinics have hastily improvised and implemented telemedicine out of necessity during the lockdown without clinical guidelines, support, or evidence about effectiveness, while increasing clinicians' comfort with digital health capabilities. These technologies have been layered upon old practice models. I highlight a few of these essential strategies here. These new SBIRT models should be informed as learning health systems, responsive to individual patient needs in real time, overcoming access, logistic barriers, and pandemic-related safety issues. Doctors Breitinger and Ramans will now talk about what this means for patients and the clinical practice, and what our next steps for this line of research should be.
I'm Scott Breitinger. I'm a psychiatrist in the Integrated Behavioral Health Division here at Mayo Clinic. So within this paper, we tried to focus on looking at how COVID has affected the addiction landscape. And something that we've been experiencing in Mayo Clinic that's been mirrored throughout the country are two simultaneous pressures. We've both recognized that there's an increase trend in the prevalence of substance use disorders and a decrease in access. So especially while the country was in various states of lockdown, what we saw was that it was difficult to provide in-person access, and that resulted in really a lot of marginalized patient populations suffering, in particular rural patients, but other underserved minorities and other marginalized groups. And one of the hopes that we had was figuring out how we would begin to translate some of those challenges into innovation opportunities. And so the work that we're trying to articulate here is how to translate the SBIRT model into a new generation of care and make it a digitally native environment for patients to seek and engage with mental health care in the primary care setting in particular. One of the things that I think is especially important to understand is that to implement addiction care in the primary care setting successfully, it really requires a critical amount of activation energy and an investment in the infrastructure so that the primary care providers feel capacitated with the right amount of training and support, and that we have allocated within the clinical workflow enough time and support resources so that patients can be screened and processed and routed to the right care provider. And then finally, one of the things that the evidence base has shown is that in the primary care setting, providers don't anticipate or expect the SBIRT model to be effective. And so part of the work, I think, is going to be creating a feedback loop to be able to demonstrate that the outcomes and the engagement with care is effective and is followed through upon by the patients in the primary care setting, so that we have greater investment from the primary care providers. One of our goals in translating this position paper into research and implementation is in piloting a digitally native SBIRT and care coordination program within Mayo Clinic. Fundamentally, we think that the most important thing is to put addiction care resources in the primary care setting where most patients are going to enter their care journey and where the screening should take place.
Hi, I'm Terry Rummins. I'm the Donald Lucy Dayton Professor of Psychiatry here at Mayo Clinic. I've been on staff for 35 years working as an internist and a psychiatrist, the interface between the two. And in today's world, one of the major issues facing the interface between the two is the alcohol and drug problems that we're all facing across this country. It's rising significantly and affecting most patients that are coming into the clinics in one form or another. So the old models that we have had in the past are inadequate to meet the needs of what is occurring in the future. So the types of things that Dr. Kamek and Dr. Breininger have been talking about is extremely important if we're going to be able to meet the needs of those who are suffering the most with alcohol and drug problems. And in fact, there was a study that was just published recently and came out today talking about how we are starting to make some inroads by the use of telemedicine in the problem by reducing opioid overdoses. And so the things that they have been talking about are extremely important for the patients of today.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.